Okay, I think that then we can start the recording. Okay, thank you very much once again. My name is Alexei Lakhov. I am the project executive of the European Network of People Who Use Drugs. And today's webinar is dedicated to our technical briefing that we produced under the BOOST project implemented by our partners from the Correlation European Harm Reduction Network and also several other partners. So this technical briefing is called Community-Led Approaches to HCV Testing, Treatment and Care. And today you will hear several presentations. First will be from Katrin Schiffer, the Executive Director of the Correlation Network. Next, John Melhus, our Project Manager for peer-led harm reduction resources, will tell you about what these resources are and how this technical briefing actually came into being. Then our operations manager, Lynn Jefferys, will show you a video detailing the production of these resources. Then hopefully we will have our members from Portugal who will tell about their own experience in community-led responses to hepatitis C virus. Then we will see a Hep C bus video from Norway. It's a really interesting example of how this work can be done on the wheels, so to speak. Then John will take the floor once again and tell you about the research done on the results of this work of this Hep C bus. And then I will talk a little bit about advocacy for access to treatment and about some personal experience of treating both chronic hepatitis B and hepatitis C. Okay, I think that in terms of the introduction, that's it. I hope that all the other people who are joining us or who weren't able to join us today will see this recording afterwards. And now I would like to give the floor to Katrin Schiffer to talk to us a little bit about the BOOST project. Please, Katrin, the floor is yours.
Thanks, Alexei. Yeah, first of all, thanks for inviting me and for being part of this webinar. I think, Lynn, can you do the next slide? Yeah, so I will be presenting on only very short, giving a short introduction about the BOOST project, which is an EU-funded project from the EU for Health program for 3 years. We started last year in January, and it is a 3 years project. So we are just in the midterm. We have 1.5 years more to go, and the project is built on the idea that we all know. I mean, HIV/AIDS and viral hepatitis pose a burden to public health in Europe, and people who use drugs are disproportionately affected by this. And we also know that harm reduction is an effective and leading policy response, and then not only harm reduction, but also community-based and community-led services should be strengthened in this context. This is also stressed by WHO and other important international organizations. And this is especially if we want to eliminate HIV/AIDS and viral hepatitis by 2030. This needs to happen. The project, next to the EU, we also include neighboring countries in the project, which I think gives the project more impact. The next slide, please. So if you look to the project itself, we have the main aim of the project is to enhance the implementation of community-based and community-led communicable disease services, which is horrible, and when you speak it, when you say it. And we really want to scale up these services and also improve a people-centered integrated approach. We have 4 content-related work packages, so to say. The first one is informing. So this focuses on the collection of information and data from community-based and community-led services, focusing on people who use drugs. There, for example, we produce our annual monitoring report on hepatitis C, but we also have, for example, published or carried out a major survey, which has just recently been published, a multi-modular survey where we reached out, I think, to 65 different services across Europe. It was a huge survey. And there we really were looking into gaps, challenges, and needs. The second work package is the Improve. This focuses on capacity building, in particular in the field of digital skills. So a number of webinars have been organized, a number of currently what will happen is that we will develop together with the group and experts quality standards for digital services. And there is also a kind of mentorship program to support organizations in scaling up their skills in this field. Support. This is one work package, what we also call the lighthouses. So we have identified 4 best practices in different countries, which also will work with mentorship programs to scale up and support other services in the field to improve the quality, but also the access and availability of their services. And the last one is the Connect and Act, where we actually cooperate with the 4 European networks, which is Correlation, European Harm Reduction Network, EuroNPUD, Eurasian Harm Reduction Association, and the Drug Policy Network Southeast Europe. And together with these networks, we have carried out a number of online consultations, I think a total of 8, where we reached really nearly 100 people. And we also collected input to develop a joint advocacy strategy, which was finalized during a meeting in Amsterdam, where different experts came together and analyzed and reviewed the input from the consultations. And the strategy is, in the meantime, it is published, and we are now working on the implementation of this. So these are the 4 content-related work packages, interrelated work packages. Important, because I didn't mention that now, is that EuroNPUD is involved in all 4 work packages. And I think this is something really new and good, that we can involve them. So, for example, in the work package on Inform, they carried out focus groups, the same about organized webinars in the capacity building one, contributed a lot to the Connect and Act work package in the development of the strategy, and also in the lighthouses, they are actively involved and also supporting community-led organizations in scaling up their services. If you go to the next one, I just wanted to show you the collaborating and associated partners. So we have the Correlation as a coordinator, Eurasian Harm Reduction Association as a member, official member of the project as network. Then we have all the ones in black are the project partners, which are mainly focusing on specific activities in the work packages. And Drug Policy Network Southeast Europe and European Network of People Who Use Drugs, unfortunately, we could not include as official partners, but they are included as associated partners in the project. If you go to the next one. Yeah, so here you see one more time the involvement of Europe input. So there, when it comes to the work package 2, EuroNPUD has been greatly involved in the data collection, in the COBA test adaptation. So this is another thing I forgot before. Those who do not know COBA test, it's community-based testing survey. And one of the aims in the work package was to adapt these to the needs of people who use drugs. And also there, EuroNPUD contributed significantly. Also by in the webinars, and there you see that in principle in all the different activities EuroNPUD has been involved, and I think this offers us and hopefully also EuroNPUD opportunities for mutual learning, and I hope this is also the start for new and more joint activities. The next one. Now, I just wanted to add, it's not really because we just finalized this advocacy strategy. This is what we developed, or these are the priorities we extracted from the consultations. And this is probably something where I hope that together with EuroNPUD, we will be able to work on these. So one is the political will, which is an important one, that we want to increase political will. The second one is to promote community-driven harm reduction, then to ensure access to specific health services for people who use drugs. And the fourth one is ensure universal access to comprehensive health and social care. And this also includes integrated care services, for example, mental health and other services. I think this is the last one. Yes. So thanks a lot. This is my introduction. I'm not sure how we deal. If there are any questions or.
Thank you very much, dear Katrin. If we have any questions, you can ask them either by raising your hand or by posting in the chat. Okay, you had your chance. If not, then sorry. Okay, then we can move on to our next speaker. This is John Melhus, our peer-led harm reduction project manager, and John will tell you a little bit about how this peer-led harm reduction project came to be, and how the community-led approaches to HCV testing, treatment, and care technical briefing was developed. John, please, the floor is yours.
Thank you very much, Alex. Hello, everybody. My name is John Melhus. I'm the EuroNPUD peer-led harm reduction project manager. I'd like to start by telling you a bit more about EuroNPUD. Next slide, please. We're basically a network of people who use drugs and all around Europe, and we're promoting the health and defending the rights of people who use drugs in Europe. EuroNPUD consists of 7 teams. We have the Sister EuroNPUD, the Women's Network. We have Drug User Organization Development Project. We have Network Strengthening Project, OIT Project. We have a campaigns team doing really cool stuff, and advocacy team, and lastly, the peer-led harm reduction project. Next, please. So if I also wanted to say here, so if you are not yet connected with EuroNPUD and you feel you could contribute in any way, please feel free to take contact anytime. So now to the 3 resources that we have ready or almost are ready with. We have already launched a peer-to-peer distribution of naloxone, P2PN. Green one at the right, which we introduced last year. This year, during this session, we're launching the community-led approaches to HCV testing, treatment, and care. And later this year, we'll be coming up with the peer-to-peer needle and syringe program. Next. We also have a safer injecting course, which we will also be officially launching later this year. This is about empowering peers and giving the power of learning how to use and to inject safer, which yeah, well, you can get to. We'll let you all know when we're going to launch this a little bit later. Next. Okay, and the whole idea behind peer-led harm reduction is, of course, the strengths. It's because peers usually have privileged access to drug-using venues. You have access to drug supply systems. You have formal and informal mutual aid networks. You have access to drug scenes. You have trust from peers, and you have the shared lived experience, all which are really good strengths in order to reach each other with information and good information. Next. So now to the program at hand, the community-led approaches to HIV testing, treatment, and care. This resource was written by myself, Lynn Jefferys, and Lana Dubrovka. And yeah, next. What we found, I think, is as a kind of like a rounding up of the things we found, is that the main benefits of community-led initiatives is basically that you're breaking barriers and reaching people who would otherwise not be reached and out of the system in a way. Some people are really afraid to go to the doctor or go to hospital, and in this way, community-led initiatives are really important. Next. The benefits of community-led initiatives is also connecting the health services with the people who use drugs. It's cost effective. For example, one health worker says it's cost effective because it saves us the multiple drives to the hospital with one person at a time, you know, and so in this way it's cost effective and time effective. Next. And the whole, actually, the key benefit of community-led approaches is that it's one streamlined process. It's fast, safe, friendly, easy for the user, and efficient. You diagnose, you treat within a very, very short time, and this reduces dropout underway, which is very often the case in traditional systems. So yeah, next. Yeah, that was it from me actually. You'll hear more from Lynn about the work on the resource itself.
Thank you very much, dear John, for summarizing how community-led approaches are actually effective, and efficient and cost-effective for good measure. And if you do not have any questions to John now, you can actually ask them in the end when we have the session for your questions and for our answers. But now we would like to go to Lynn Jefferys, the operations manager of EuroNPUD, and Lynn will show us the video on the development of the resource that we are talking about today. I think we do not have sound.
Just give me 1 second.
Yeah, sure. Thank you. We are on time, so we can tweak it a little bit.
Thanks, John, for the introduction. Hi, everyone. My name is Lynn Jefferys. I'm the operations manager for the European Network of People Who Use Drugs. I'm also the project manager in charge of overseeing EuroNPUD's involvement as a network in the EU for Health Boost project, a project under which this resource has been able to be developed. I have a background in frontline harm reduction work from the Coast Salish territories in Vancouver, Canada, as well as now where I'm based in Dublin, Ireland. I'm also a professional consultant with lived and living experience of drug use. I became involved specifically in the field of drug user advocacy and peer-led best practice in 2020. I currently hold a postgraduate diploma in substance use from Queen's University Belfast, and I'm going to speak to you briefly today about the development of this resource. So the development was made possible through our partnership with Correlation European Harm Reduction Network and Podena within the EU for Health Boost project, which is co-funded by the European Union. The EuroNPUD Boost team consists of a devolved team of work package project managers based in Portugal, Norway, Ireland, and Germany. For this collection of best practice, we developed a protocol for the team members, which outlined the country organizations, methodology, and timeline. We also worked with InMouraria and Prolar to collect organizational information and statistics on each of their country contexts. For existing datasets, we accessed the information from the European Monitoring Centre for Drugs and Drug Addiction, or the EU Drugs Agency, as it's soon to be called. For InMouraria, questions were developed for peer workers as well as people who access the services, acknowledging that these would often intersect and that the peer workers were not restricted to abstinence in order to support the organization. Joanna Canedo, EuroNPUD project manager and member of MANUS peer group, provided facilitation and translation assistance for the interviews at GAT in Lisbon. Peers who were interviewed were compensated in cash for their participation, and service providers were given a donation for their time and contribution to this invaluable project on community-led responses to communicable disease. While perspectives were gathered from both service providers as well as people with living experience, the resource, the expertise of people with living experience of HCV and people with peer work experience were prioritized in this report. The established focal points for each country context were an integral part of the process, providing an established connection during the interview, allowing for more robust sharing of information, also allowing interviewees to answer in their own language, and then providing translation added to the comfortability of the process for peers. Overall, the process provided insight for participants, service providers, and our own team into the best practice around meaningful engagement, participatory research, and how to involve people who use drugs in the development of technical resources that reflect community-led service design. So while we've developed this technical briefing for you all, it was also a great experience for us as a team. And that's it. I'd like to thank John for facilitating this webinar and asking me to speak today. I'd also like to thank the peers and partners in Portugal and Norway. And as a special mention, that the in-person interviews in Lisbon in June 2023 would not have been possible without the support of the European Drug Summer School hosted by the EMC DDA. Thanks very much.
Thank you very much for this presentation, dear Lynn. You have mentioned several participants from Portugal and Norway, and we are happy to have Maria Luisa Salazar from InMouraria today to tell us a little bit about how this project came about and what the main lessons from working with peers in the HCV prevention, treatment, and care are. So, Maria Luisa, please, the floor is yours if you are ready to speak.
Hi, everyone. Good afternoon. First of all, thank you so much for the invitation. My name is Maria Luisa, but some people call me Malu, and I'm here representing InMouraria from Lisbon, Portugal. And I would like to thank EuroNPUD for the invitation and the opportunity to share here our experience that has been quite an amazing adventure of God providing testing, treatment, and care in a community-led framework in Lisbon. So after this presentation, unfortunately, I will have to leave, but please do not hesitate to send me emails to the email to share some ideas or to visit us. I will leave here my email, so if you want to contact us, feel free to do that. So I'm going to share a small presentation, and if you have some questions, please then ask me. Let me see. I cannot share this. Okay, now I can. So. Can you see the presentation? Yes? Okay. So just a few context. GAT is a Portuguese organization based in Lisbon that was founded in 2001, and it was built by the different communities and organizations that are affected by HIV and AIDS, sexually transmitted infections, viral hepatitis, and tuberculosis. Nowadays is a big organization in Lisbon and in the south part of Lisbon. And we have many services that each different service that is directed to a different key population, and we work mainly on prevention, early diagnosis, and access to health service treatment, and to work. We also investigate about discrimination that is lived by people who live with HIV, and evidence-based interventions. So based on the motto, nothing about us without us, GAT is actually an activist group, and it was funded and is still nowadays built by the own members of community, because we believe that the people are the experts about their own lives, and people should have a voice while designing public policies and also services that are directed to themselves. So now a small introduction to InMouraria that I think that many people here present already been there or heard of it. We are a harm reduction center for people who use drugs and people who experience homelessness in a very historical neighborhood of Lisbon that is called Mouraria. And it's a low threshold service, so everyone can have access. Just need to enter through our doors, and people don't need to have access to our service, don't need to be registered, don't need to be documented, don't have to be regular in Portugal. So we want to provide a low threshold service. It's free of charge. We have a multidisciplinary team composed by peer workers that are the ones who have an important role in the team, doctors, nurses, social workers, and also community harm reduction workers. So we work in an integrated approach framework, which means that our main goal is to run a one-stop shop service. So a person that goes to InMouraria can have access to a wide range of social and health services and doesn't have to go through many bureaucracies or face many obstacles while accessing basic human rights such as health and social rights. We are open from Monday to Friday from 2 p.m. to 8 p.m. because we define that is the schedule that we believe, and according to our community members, is the best schedule to be open. But in the future, of course, we would like to have a wider opening our schedule. We are trying to make it work. So why do we say that InMouraria is a community-led service for people who use drugs? And this has been our mission during these last 12 years that InMouraria exists. So to create a space that is where the voice of our community is heard, and we have to adapt and to implement strategies that are pragmatic and really are attentive about our community needs. So we have some structural and very important interventions that are led by our peer workers. We in our team we have 5 peer workers that used to be service users in InMouraria, and now they work there, and they are the ones who lead the intervention in our drop-in, in our drug consumption room that is recently been recognized by the Portuguese state. The rapid testing for sexual transmitted infections also, and the outreach work. And we have to be very creative about these peer participation processes. During our opening hours, we also implement, for example, activities that incentivize our service users to advocate for their rights, or to give inputs to make our space a more welcoming and better space for our community. InMouraria is also a non-medicalized framework, because it's also it's built by the community, and all the relationships between the staff and the community members is very horizontal and very informal, which is good to get over through some obstacles that many people face in more formal settings. Of course, we are our main flag is harm reduction, and it's our mission. So we have a non-judgmental and non-moralistic approach. So in a small drawing, here I can show you the types of services that we provide in that very small space. For those who've been there, they know it's a small space. We can give a wide range of services, like some food, access to computer and internet, hygienic products, clothes. People can have access to their mail, because people who experience homelessness can have through InMouraria an administrative address. People can have access to safe material to smoke, inject, or snort drugs also, lubricants and condoms. We have also peer counseling, social workers, nurses, and then also physician general doctor appointments, and also mental health appointments by psychiatrists and psychologists. So in this small space, a person enters, and in order of arrival, a person doesn't need to have an appointment or to identify, can have access to this wide range of services. Further than these services, we also have the Hepatitis C decentralized consultations that I'm going to talk a bit about it. So why did we want to implement this initiative? Because we noticed that was a high prevalence of hepatitis C infections among our community in our center, and the small proportion of people who initiated the treatment in primary care settings, and the significant number of patients who didn't complete their treatment course after the treatment initiation. As many of those diagnosed continue to come to InMouraria because they feel like it's a safe space and they are not judged, is flexible, and the relationships between the staff and the community are horizontal and non-judgmental. We noticed that it was being in the community, and it was a big opportunity to reconnect people to care. So what kind of strategies did we adopt? So, and we still have. So we have walk-in educational sessions on safe drug consumption. It's peer or nurse-led in the drop-in and also in our drug consumption room. We have integrated rapid testing for HIV, hepatitis B, hepatitis C, and syphilis. And these tests are also performed by, by all the profiles of staff. For example, peers, nurses, social workers, all of us, we can perform rapid testing. And it means that if a person feels more comfortable, for example, considering their relationship with a peer or a nurse or a social worker, the person can actually choose to perform the test with the specific staff. Then we have a point of care PCR reflex testing for HIV and hepatitis C. And after if a person has a reactive test for hepatitis or for HIV, for example, or syphilis, the process doesn't finish there. So we promote linkage and retention to healthcare and peer navigation. So a person we provide a service that we can go and navigate with the person through the healthcare system. We also, like I told you previously, we have walking nursing and medical appointments that is in order of arrival, and it's during all our opening hours. And we also do some sensibilization, and we continue the distribution of prevention materials in order to prevent infections. So prior to the implementation of the project, we noticed that the hepatitis C treatment cascade for people who had a positive diagnosis, we noticed that 85% of people accepted the hospital referral. That only then 66% reached a doctor, and then 33% obtained hepatitis C treatment prescription. But the problem was that only 24% actually initiated treatment and just 11% completed it. Because it's the answer is pretty simple, because people use drugs, face so many stigma, and have when we actually look at the social determinants of health, we notice that there are so many obstacles to have access to treatment for our community that we needed to do something. So there was a very low rate of hepatitis C treatment and completion. So what did we do? We brought the doctor to the community. And we had to create a pragmatic and flexible solution. So people can have access from the beginning, for the first time they do the rapid test to the end of the treatment. People don't need actually to go to the hospital, and they can go to InMouraria, a place where they feel safe and understood and not judged, even by the doctor or for the rest of the staff, and can have a dignifying access to treatment. So what have we done? First, to ensure that the project ran smoothly, GAT and the hospital established an agreement on care responsibilities. Then InMouraria provided training to the staff, nurses, but also peers in point of care for hepatitis C PCR testing, followed by training in the use of the center equipment. So this PCR, it means that after we do the rapid test, if the test for HIV or hepatitis C is positive, we have a machine. The nurses operate with the machine, and they can confirm if it's an infection. And so people don't need to go to the hospital. So then we wanted to promote the peer involvement to ensure that this linkage for and retention in the decentralized hepatitis C treatment consultations, including we also do outreach work. Our peers navigate in the neighborhood, and the peers are the ones who know better our community. So they were very important in locating people who were lost to follow up from hospital-based consultations. And then there was we divided the responsibilities between GAT and the hospital. So GAT was responsible to be the point of care PCR for hepatitis C confirmation of infections, to book the decentralized consultations in GAT InMouraria, so because the doctor comes twice per month to the harm reduction center from the hospital, then to do the sample collection for analysis and the medication regimen adherence. This last responsibility is also very important because many people who experience homeless, they don't have where to put their medication. So our nurses can keep safe in GAT InMouraria and can help to manage the medication adherence. The hospital was responsible for the FibroScan that we also have in InMouraria, for the hepatitis C treatment care and monitoring, to transport and to process the laboratory samples, and to give the medication and to transport the medication to GAT. So from September 2020 to the present moment, 156 people attended the decentralized consultation, and 72 people were cured, finished the treatment, and 6 are still undergoing treatment. It has not been a very easy process because it takes a lot of bureaucracies and a lot of obstacles. These numbers might seem a little bit negative if you notice in the beginning, but actually if we confront with the other results that I showed previously, we notice that it's a struggle, we know, but there's something positive and some positive results here, and it's a fight that we have to continue, and only with community led interventions this is possible. So this is my short presentation. I will have to leave after this presentation, so don't hesitate to message me, and thank you so much.
Thank you very much, dear Malu, for your presentation and for the enormous work that you have been doing for so long and so successfully. And I hope that your lessons will be really invaluable to all the other members of our networks. So with that, I would like to give the floor to John to show us the video about our partners from Norway. And this is a project that is called Hepatitis Bus. John, could you share the video, please?
Yes, thank you. I think it'll start pretty soon. Lynn, I don't know if you can start it. I think I'll let the video speak for itself, and I'll say some words about it afterwards. It's texted in English.
I Norge kan så mange som 15 000 mennesker være smittet av hepatitt C. De står i fare for å utvikle leverskader og i verste fall leverkreft. Hepatitt C kan være dødelig. Problemet er at mange ikke vet at de er smittet.
Skal til Lillestrøm. Noe av problemet i forhold til lever og hepatitt C var at folk med rusproblemer ikke kom seg til sykehuset. Så da tenkte vi at vi kunne lage et prosjekt hvor vi oppsøker de da. Hepatitt C har jo blitt betegnet som den stille epidemien. Viruset kan ligge latent i mange, mange år før man utvikler skade på det, noe som gjør at det er vanskelig å oppdage.
Hepatitt C er en betennelse i leveren, forårsaket av et virus, HCV. Viruset smitter gjennom blod, derfor er injiserende rusavhengige spesielt utsatt. Mange med infeksjonen får ingen symptomer, men for noen vil infeksjonen vedvare og kunne bli kronisk. I noen tilfeller kan det bli svært alvorlig og føre til utstrakt leverskade og leversvikt, eller leverkreft.
Den gode nyheten er at nå har vi behandling som virker på et helt annet nivå enn tidligere, og som vi også har gjort tilgjengelig.
Vi har fått en veldig effektiv og grei behandling, og det hadde vi ikke før. Da hadde vi en komplisert og ubehagelig behandling. Nå har vi en veldig effektiv behandling, og det gjør det også mye mer realistisk å ta dette problemet med rota og behandle alle som er infisert med hepatitt C. Veldig effektive, 1 tablett om dagen, 12 uker, og så å si alle blir bra. Det kan egentlig ikke bli bedre. Så det er en medisinsk solskinnshistorie.
Men det hjelper ikke med behandling hvis en ikke vet at en har hepatitt C. Og det å få folk til å teste seg, det er ikke alltid like enkelt.
Alle som har hepatitt C, gjerne i tidlig stadium, bør få behandling.
Denne bussen driftes jo av vår brukerorganisasjon, og det betyr at bussen og prosjektet er brukerstyrt. Og det vil si at vi som jobber på bussen er tidligere rusavhengige, og at det er vi som har satt i gang dette prosjektet da. Nei, gikk bra.
Ja, det gjorde det. Veldig bra opplegg.
God dagen. Hei.
Erik.
Ronny.
Er det her en kan ta sånn hepatittest?
Det kan du gjøre.
Ja, ok. Hei.
Hallo.
Erik.
Solveig. Hyggelig.
Og så er jeg i LAR, og jeg har vært rusfri i 10 år nå. Jeg går på Subutex, og nå i det siste så har jeg tenkt at det kunne være lurt å ta en hepatittest. Jeg tok en test når jeg fortsatt var rusavhengig, men jeg tok ikke oppfølgingstesten.
Ja, men jeg tenker vi kan ta en kontroll. Hvis jeg fyller ut litt informasjon om deg først, og så skal vi ta et lite stikk i fingeren.
Ok.
Ja, og så da får vi svar på blodprøven innen en time.
Wow.
Og så skal vi ta ultralyd av leveren.
Aha, ok.
Ja.
Da gjør vi det.
Yes. Det er veldig viktig å ha et ambulerende tilbud for denne pasientgruppa. Å ha en sykehusavtale klokka 8 eller klokka 10 er vanskelig. Nå er vi en buss som står og tar imot, altså nett når det passer for pasientgruppa da. Så kommer det et lite stikk.
For et par år siden var det vanskeligere å få behandling for hepatitt C hvis du ruset deg. Nå har man endret på kriteriene og gjort behandlingen tilgjengelig for alle.
Sånn. Er det greit?
Ja da.
Ja.
Det er jo en gruppe som faller mellom alle stolene. Det er en brukergruppe som ikke bryr seg om det som er innvendig. De har nok med å leve det som de trenger, og det utvendige.
Sånn. Da er det cirka en time, så er vi klar. Ja. Men da kan vi ta den fibroscannen. Ja. Kommer det litt kaldgelé. Så ikke det er alltid like enkelt å finne leveren.
Nei.
Så da må jeg lete litt grann først. Da kommer det et lite dunk. Er det greit? Ja. Det var siste.
Vi tenkte at det må være viktig å ha et prosjekt som oppsøker brukerne der hvor de er. Sånn at når vi møter dem, så blir det mye kjappere en god relasjon, og det er trygghet, og man har tillit sånn veldig tidlig.
Da har jeg fått svaret på blodprøven din. Du var positiv.
Ok.
Så du har hepatitt C.
Jeg hadde jo en mistanke om det.
Det går fort godt dette her. Altså, du hadde ikke noe utslag på prøvene dine, altså på leverprøven din. Det er en 12-ukers tablettkur, en tablett til dagen. Noen kjenner litt på hodepine, men hvis du drikker nok med vann, så går det greit.
Så det er ikke noe verre enn hodepine?
Nei. Flott.
Tusen takk for meg.
Takk for at du kom, og lykke til videre.
Jeg er veldig glad for at jeg kom.
Du, jeg har hatt en kar her inne i dag. Vi tok fibroscan, og blodprøven var positiv på prøven.
Dersom prøvesvaret er positivt, kontakter vi nærmeste helsepersonell for igangsetting av behandling.
Ja, ha det.
Vi ønsker å være med på å bidra til at myndighetene får eliminert det viruset her for godt, da.
Jeg synes det er viktig å si en enkel ting, at alle som noen gang har tatt stoff med sprøyte, de må få testet seg for hepatitt C.
Tusen takk for den viktige jobben dere gjør, og jeg er veldig glad for at dere også skal fortsette jobben neste år. Lykke til videre.
Okay, thank you very much, John. This is a really informative video, and I believe that there was a research done on this hepatitis bus, and it was published in the Liver International journal. Could you share some results, please?
Yes. Well, actually, I just like to say a couple of words more about the hepatitis bus, because it was a close knit of the peers. On the one hand, doing everything from the diagnosing, testing, getting the results. And in principle, all they had to do was make a phone call to the doctor who would prescribe the medication, which would be available the next day for the patient to use, which is what I was talking about a little bit earlier, a very streamlined process where you don't lose anybody underway. You don't have to go back and forth to hospitals. So this is a really effective way to meet the users. And the doctor you saw in this video, together with the peers, have written a paper on this project. It's peer support in small towns, a decentralized mobile hepatitis C virus clinic for people who inject drugs. You can find it on the PubMed. And yeah, basically the conclusion shows that a peer-driven mobile HCV clinic is an effective and feasible model of care that should be considered for broader implementation to reach people who use drugs outside of the urban centers, which is, yeah, I think that's basically the thing I had to say about this this project. I think it's a wonderful project, by the way. Thank you.
Thank you very much, dear John. I think that the link to this website, to this research was posted in the chat, so you can access it as well. And now it comes to me actually to talk a little bit about the access to treatment advocacy that we implemented back in my home country in Russia, and also about my personal experience of treating both chronic hepatitis B and hepatitis C viruses. I think that maybe this information will be useful for some attendees of this webinar and also for some viewers as well. So basically, I got infected with these viruses in the end of 90s when I was injecting different substances, and in 2008, the first symptoms of chronic hepatitis appeared. So basically, these were fatigue, loss of interest in anything and anyone, even, you know, and some kind of a mental fog. So these are just like, you know, common symptoms of hepatitis. And so I signed up for a treatment program. It was a stay and run program. So the medications were provided free of charge. And it was a standard interferon therapy. So I had 3 injections a week and plus pills every day. And so this program lasted for a year. And in the end, I was treated I was cured of hepatitis C, and actually this treatment was quite awful, because after each injection I had a temperature, you know, and you had this like flu-like condition all the time. So, and you got really nervous, you got really angry. So that's why when the so-called direct acting antivirals appeared, it was a real breakthrough, because this interferon-based treatment, it was not effective. So only 20 to 30% of people could actually get treated with it. But I was one of the lucky ones. I got treated from hepatitis C with this therapy, but my hepatitis B didn't go anywhere. So, and in 2017, my doctor prescribed me another medication, this time for the chronic hepatitis B virus. It's called tenofovir, and it is actually one of the most effective treatments currently available for hepatitis B. Another one is entecavir. So basically, these are one of the most popular and one of the most effective treatments. And also in 2015, I started to work in the field of viral hepatitis prevention and treatment. So basically, I was a peer counselor on the free of charge hotline of a community-based NGO that was called United Against Hepatitis. And during my work there, I received over 700 calls from patients, from their relatives, from their loved ones, and I shared my own experience, and also I shared some insights from doctors and other medical specialists in different media stories, you know, as a person openly living with chronic hepatitis. So I also participated in some information campaigns from WHO European office and also from the World Hepatitis Alliance. But one of the most important things that we actually did was around the advocacy for access to treatment. You know, for example, one of the campaigns that we implemented, so we produced these postcards. We sent these postcards to different regions for our activists living there, and we launched a campaign called "Congratulate our Prime Minister with the World Hepatitis Day." As you know, it is celebrated every year on July 28th. And so activists from all over Russia started sending these postcards to the Prime Minister, asking him to develop a national plan and a national strategy on hepatitis. And so we also published some news about it in the media, you know, on social media. So I think it was quite a successful campaign. And also we launched different petitions, position papers. We were active in mass media on hepatitis and on the interconnected issues such as HIV infection, for example. And I think that our work actually bore fruit, because in 2021, the president of Russia actually gave the order to eliminate hepatitis C as a public health threat by 2030. So this work is still ongoing, you know, because due to the Russia's aggression against Ukraine, all the healthcare and all the other budgets were diminished, you know. So that's why not a lot of money is currently being directed towards these infectious diseases. But still, we hope that due to this decree, this work will be continued. And as for my own hepatitis B story, several several years later, after I started treatment, I received the news that actually I achieved the so-called functional cure. It's actually a really rare occurrence. Only 5 to 10% of Hep B patients achieve it during their lifetime. It means that my ASH HBS antigen is not detectable anymore, but in case of some really hard treatment against against cancer, for example, or in case of taking some immunosuppressant therapy, this virus can be reactivated. But officially, I am undetectable. So I think it's also a good example of how you can be treated of these viruses if you are adherent to treatment, if you follow the recommendations of your doctor, and if you are active in the field of the prevention and treatment of hepatitis C and B viruses. So that's it from me now. I think that we had a really nice webinar today. We actually have time left for your questions and for the discussion. So if you would like to ask us anything, or if you would like to share your own stories and your own experiences, please do it now. The floor is open for comments and ideas. Thank you. Okay, so we have a comment from Rachel in the chat. It's been amazing to hear what's going on throughout Europe, and they are overseeing a peer-led initiative in Wales and would love to keep in touch with any further developments. Thank you very much, Rachel. We will definitely keep in touch. No problem around your camera. It's okay. There was a question around could we share this video more publicly? Yes, you can share this video and also this link to the research, and this link will be the link to the recording of this webinar will also be available, so you can share it as widely as possible as well. Okay, we have several hands up. Okay, I see Daphne and Georg. Daphne, please, and then Georg. Daphne, you are muted.
I wanted to ask to be last, but I wanted to say that I find Boost a very useful program and a project, and I was amazed again by what our member teams are doing around. We're proving that peers are very important. Also, there's something we never mentioned, and I wanted to add it. I feel a bit shy to say it because I've avoided speaking about it, but there is hepatitis C creates another very serious problem, which is, I'll tell you something very, very personal. I've never mentioned before. I lost my baby when I was 20 years old because of hepatitis, because the dehydration was something that the doctors didn't realize. And it's something we never really speak about, but it affects our women so deeply that some of us never speak about it. It's a very painful experience, especially because for many women, the moment they decide to keep a baby is the moment they decide to change many things in their lives. So I hope I wasn't very dramatic and didn't make you sad. I wanted to thank you very much, all of you, for being parts of it. And I believe sharing this webinar will help some of us who live in countries that are not very advantaged convince or bring arguments about peer involvement to our legislators. Thank you all. Georg, I think.
Thank you. Thank you very much, dear Daphne, for sharing your personal story. It's really touching. And Yeah, thank you very much. Georg, please.
Yeah, I just can extend to what you said, Alex. It's so important that these stories are shared, because that's then the possibility also to get a wider picture of so many different populations. And also, I've just introduced myself briefly. I support Katrin in coordinating the Boost project. So sometimes Katrin makes presentations, sometimes I, but we are in this together, and I'm super happy to be also in this webinar. And for the 1.5 years that I've been involved in Boost now, it's also that you always have to think about who do we forget? Is it not special populations, women, migrants also? So always ask ourselves the questions, do we represent the people with their most pressing issues also? So thank you also for reminding us, Daphne, about this. But I wanted to say something else. First of all, congratulations to all the presentations. And I had a question about the bus. I thought it was a super interesting initiative. And at some point you said it is feasible. Question was a little bit, what do you mean with feasible? It's also, is it cost effective? How many do you reach? It's in a rich country. Can poorer countries also afford this? So that was a question that came up to my mind. Thank you very much.
Thank you.
Thank you.
Yeah.
So I'll just jump in there. No, well, basically, even in Norway, where one would think that everybody would dare to go to the hospital and dare to go to the doctor, even there, people who use drugs, that we've been stigmatized for so long, and that going to many people don't trust the system generally, and especially not the medical system. So we get to reach those, which is one of the strengths, because they can speak to the people in the hepatitis bus as equals and peers, and they feel that they can be honest. They're not afraid of any reprisals from the system or anything like that, and it doesn't really matter where they are in their drug use, which would be an issue in the medical system. So those are the definite and feasible. When speaking to some of the service providers who were at the same site where the bus stopped, they said that this bus saves us so much time, because we have to drive to like hospital once to get them tested. Then we have to drive them again to get the answer, and so they would save multiple drives to and from the hospital, which demands a lot of resources, and therefore the feasibility issue as well. I hope that's a good enough answer.
Super, thank you. And that was exactly the niche that I was looking for, because sometimes you have nice plans, but really to demonstrate that it is also efficient to work in a certain. Thank you.
Thank you very much, dear Georg and dear John. Before going to Wes, who has his hand up, I was just going to address this question myself, because actually in St. Petersburg we had several mobile units testing people for HIV, but also for hepatitis B and hepatitis C. And I used to work on this mobile unit. And it actually showed the importance of such work, because a lot of people, they were aware about HIV infection, for example, in terms of AIDS, like being a plague of the 20th century, and all the other stuff. But a lot of them haven't actually heard about hepatitis. They thought it was like a usual disease of people who use drugs. Like a flu, for example. And when they came and they got tested, and they found out that they were infected with hepatitis C, for example, and we started talking with them and actually telling them about, cirrhosis, about other diseases that are actually related to hepatitis, because this is a virus that affects not only your liver, but also your central nervous system, and all the other systems of your body. So they were really impressed, they were really surprised, and they wanted to find out how to get treated, and I think that in terms of raising awareness about hepatitis, such mobile units are also really effective and really useful. So thank you very much. And now we go to Wes. Wes, please.
Thank you to all the speakers as well. Just yeah, a wee question to anybody who wants to try and answer it, I guess. What do you see as the biggest barriers to implementing community or peer-led initiatives, I guess, as opposed to community or peer-involved? I think there's a bit of a difference between peer-led and community-led work as opposed to community-involved. With a wee follow-up of how to overcome, or any advice or guidance in overcoming, I guess, some of those barriers.
Thank you very much, dear Wes. I think we have so many experts actually on the call now that probably if you would like to start, John or Lynn, I don't know, or Georg, you can do it and just share your opinions on this matter.
I'll come in quickly there and respond to that. It's a good question, and I think that one of the barriers is not only funding, but sometimes political will and like the will of organizations. So I think organizations that are established that either, you know, work with people who use drugs or for people who use drugs, I think that these organizations maybe have the capacity and can explore kind of ways to support people who use drugs, to mobilize or foster kind of leadership, you know. A lot of the times funding and physical space are big barriers that organizations can support. So that would be maybe a barrier and a solution in one answer.
Thank you, Lynn. Georg, please.
Yes, if I may add to that. I mean, first of all, we all know how important it is from the beginning of the AIDS epidemic, for instance, and that it was not only involvement, but really also the led part that people also had influence on policies. And so, I mean, there's no doubt about it. What are the barriers? For several times I was involved in the Dutch AIDS Foundation, also international programs, and they at some point really made a management decision. We want to be more diverse in our organization, and it needs really also a policy. It costs money, it costs time, because things need to be translated in different languages, for instance. But they did succeed. If I, once again, every 1 or 2 years I'm there for some freelance work, and I see how in the last 3-4 years the organization has changed. And that's also what I just said earlier, a little appeal to ourselves. Always look at ourselves. Are we the ones who represent the people best? So we need to ask this question all the time. And if an organization or a program decides to be more diverse, more inclusive, then you also need to develop steps to get there. And it needs different, maybe also different language could be important, to speak simpler, to speak in a different appealing way, also including younger people. I mean, if you look, especially also in the HIV field, and the first generation, they're now getting retired, like myself, who have been involved from the beginning, but make sure that the younger people are involved, and also then we must adjust maybe our procedures, the timing, so many elements that you have to consider. That would be my comment on this.
Thank you for your insights, dear Georg. Does anyone else like? Yes, Daphne, please.
I want to add, I agree with Georg, and I believe funding, as Lynn said, and all that, and is very, very important. I want to mention something that is not very popular between ourselves, because it's not good for us, it's not helping us to mention, but I need to do it because I found it a problem. I found a problem with this. It's our self-confidence. Our community has been stigmatized so long, and there are many differences between the gay movement, where you had people who had studied, who had been to universities, who had worked, and suddenly had a problem with their health. Many differences to our community, where you had people who had to live in almost in the streets without work, being under the law somehow. So self-confidence and trust of each other sometimes becomes a serious problem. And this is something I always want to fight. and make us more trusting to each other and more believing more in our community and in ourselves. This I mentioned, although it's not very popular and clever to say to the funders, but we have to acknowledge that, I believe.
Thank you very much, dear Daphne. Actually, I wanted to comment on this matter myself, because in June I was at the International Liver Congress, you know, and it used to be an event that dealt with different hepatitis, you know. But now it seems like hepatitis has been put on the back burner, so to speak, you know, because there are direct acting antivirals, because the hepatitis B vaccine has been around for ages, you know, and now a lot of conversations are around other liver-related diseases, you know, and liver-related conditions. But in terms of raising awareness about hepatitis, it is still a very topical issue, because, for example, people know that they can be cured of hepatitis C, but they do not always know that they can get reinfected with hepatitis C, you know, because this is a really unstable virus. That's why there is no vaccine against it, you know, and not a lot of people actually know that you have to check the level of your antibodies, even if you had the hepatitis B vaccine, for example, you know, and these are just those things that make that they make this problem really topical, you know, and this is actually one of the barriers that we have to overcome. We have a hand up, Yenko, please.
Yeah, I would like to say that in Slovenia, we as a drug users as a community, we never succeed to evolve in such a manner that we could test hepatitis C or HIV. But the legitimate, I mean, this community is much more coherent or have better luck because they really evolved in the last 30 years after 91 independence, opposing to drug users community, which went through up and downs and downs and downs. So yeah, they are very strong in this community-led testing. So they are testing for many sexual transmission diseases. We are now cooperating with these chemsex initiatives and so on. So yeah, I mean, that's why I'm cooperating with them much more than with traditional harm reduction entities. Also, maybe it's also part, I mean, doctors don't want to trust drug users, but they mainly trust, they trust more this LGTB community. Maybe that's the answer. Yeah, that's what I want to say.
Thank you very much, Yenko. Yeah. And actually, it's really important that you mentioned this intersectionality, you know, because, for example, there were several outbreaks of hepatitis A virus among men who have sex with men in Europe, you know, because not everybody knows that there is a vaccine against hepatitis A, and not everybody knows that it can be transmitted sexually, you know, as well as through unwashed hands and unwashed throats. So yeah, it's really interesting to see how this intersectionality plays along. And actually now in the chemsex community, there are a lot of conversations around hepatitis A, around hepatitis B, and also C, you know, because they are really topical. Okay, does anyone else have anything to say about it? Or do we have any other questions or comments to share? Wes, I hope that we answered your question. Thank you. Okay, if not, yes, Georg, please. Yeah.
No, just a question. Do you circulate the presentations also afterwards?
Yes, sure. We will send the recording and the presentation to the emails that are in our list of registered participants, but we will also put it on our social media. So please monitor them and share widely among your own networks. Thank you everyone for attending this webinar. We are on time and I think we had a really good and fruitful discussion. You can also access our website. This is a new look website and we hope that you will be able to navigate through it more
We don't hear you.
I
Alexei.
think Alex froze.
Frozen.
Just at the minute that he was trying to say how you
Goodbye.
can navigate our new website a bit easier. Thanks, everybody. I'm just putting the social media links in the chat there. And like Alex said, we'll have this on our YouTube, and I'm going to email it out to everybody that registered, that even the folks that didn't make it. So
thank you very much.
There's Alex back there.
Bye-bye, everybody. Thank you for being here.
Bye-bye.
Bye, everybody.
Bye-bye.